Hello friends, today we are going to discuss about International Classification of Disease 11 versus 10. Basically, I will be comparing ICD-11 versus 10. I am Dr. Suresh Badadmat, Professor of Psychiatry, working at NIMANS, Bangalore. Before I start my presentation, I would like to place this disclaimer. This presentation is for academic and training purpose only. For legal opinion, please do contact an advocate. For clinical opinion, please do contact a psychiatrist. Conflict of interest? None. In this video, I am comparing ICD-11 versus 10. The main reason for comparing ICD-11 versus 10 is basically, if you know about ICD-10, by comparing, you will be able to understand what are the changes have occurred in ICD-11 and you will be able to remember easily. And this video is basically from the perspective of psychiatric disorder. So how to understand about ICD-11? So you have to type ICD-11 in Google browser. You'll be able to see this landing page. In this landing page, the ICD-11 browser, if you click, you'll be able to see the classificatory system here. So this is the browser page, and you can see the list of chapters shown here. The chapters are from 1 to 26, and then 2 supplementary sections. And here you need to understand, these 26 chapters and 2 supplementary sections is for entire medical illnesses. But with psychiatry, it is chapter 6. So what is it called as? Chapter 6 is mental, behavioral or neurodevelopmental disorder. If you compare this chapter 6 of ICD-11, in ICD-10, it was chapter 5. That means chapter 6 has got promotion from chapter 5 to chapter 6. Now, whenever you code for ICD-11, you have to mention 6 as the first alphanumerical number to code. Let's look into this. ICD-11, and if you look at the chapters arranged, chapter 6 is mental, behavioral or neurodevelopmental disorders. So if you click this chapter 6, you will find the subcategories placed like this. These are the chapters of ICD-11 in chapter 6. You can see the important classification from neurodevelopmental disorders to the neurocognitive disorders at the end. So this has been placed in ICD-11 like this. So if you look at, as I mentioned, the first character is chapter 6. So whenever you are going to code for psychiatry, it will be 6. The first number will be 6. And then A, B, C, D, depending upon the categories of illnesses of psychiatry. And the third and fourth invariably will be the subgroup of psychiatric disorders. Now let's compare this ICD-11 with ICD-10. If you look at the ICD-10, there were 11 chapters. Those 11 chapters starting from 0 to 9. So if you look at the 0, it starts with Kraepelin classification. That is, starts with organic disorder. Second will be the chapter is substance abuse. Third will be schizophrenia. Fourth will be bipolar disorder. Fifth will be neurotic disorder. Sixth, personality disorder. That means there is a way it has been arranged. Whereas in ICD-11, it is not in that format. Let's discuss why those differences have been formed in ICD-11. So when you compare ICD-11 and ICD-10 side by side, you can see the first chapter in ICD-10 is organic disorder. Whereas if you look at ICD-11, the first chapter is neurodevelopmental disorder. Invariably, ICD-10 did not talk about neurodevelopmental disorder. It talked about pervasive developmental disorder, and it was placed under child section. Whereas ICD-11 does not have child section. It has a lifespan approach has been taken. And ICD-11 starts with the neurodevelopmental disorder, that is from the childhood, and in the bottom you can see neurocognitive disorders. That means it ends up with the dementia, those kind of things. So this is how the classification of ICD-11 has done. ICD-10 is based on Kraepelinian form of classification, whereas ICD-11 is based upon various important factors which I am going to discuss now. Let's move further. You have seen this ICD-10 and ICD-11. In ICD-10, it is 11 chapters, whereas in ICD-11, we have more than 11 chapters. So let's discuss some of them in detail. Moving to this chapter 6 in ICD-11. Here, The principle behind the classification of ICD-11 is based on etiology, pathophysiology, and phenomenology. Although we wanted to bring this classification similar to other medical condition where we discuss about the etiology, either it is an infective condition or else autoimmune condition or cancerous condition. What is the etiology? What is the pathophysiology occurring because of the etiology? And finally, the presentation. But in psychiatry, we have not reached the level of etiology. But we know the presentation, that is phenomenology. Although there have been major groundbreaking research has occurred, but still we are not able to answer the question how this mental illness has occurred. That means there is a huge evidence gap with regard to neurobiological basis of classification of diagnosis with regard to psychiatric disorder. That means we need to take the approach of phenomenology, presentation, that is symptoms and signs. ICD-11 is based on clinical utility and also globally applicable or not and evidence-based. That means when ICD-11 was planned for drafting by the WHO, they kept very clearly in mind. That means across the globe, the clinical utility should be there. That means how a registered medical practitioner, a doctor, a psychiatric nurse, or a psychiatric social worker, or a clinical psychologist, how they are going to use it. And it should be easy to use, and it should be easily applicable across the globe. And it should be evidence-based. That was the three main aim they have kept it for the classification of ICD-11. And when it was planned, they also kept in mind that WHO, the World Health Organization, and American Psychiatric Association wanted to harmonize between ICD-11 and DSM-5 so that if there is any changes, they should be minor, but they should be in harmony with regard to classificator system. Along with this, if you look at ICD-11 has 21 disorders, that is subgroup of classification, whereas ICD-10 has only 11. That means ICD-11 now has got 10 more subgroup of classification of chapters, whereas in ICD-10 it is only 11. ICD-11 has omitted a separate subcategory for child and adolescent disorders, which was there in ICD-10. In ICD-11, they have removed this child and adolescent and they have taken a lifespan approach. That means it starts with the neurodevelopmental disorder, ends with cognitive deficit. Suppose if you take ADHD, attention deficit hyperactive disorder, it is not only seen in adolescent or in child, it is also seen in adults. That means the current ICD-11 has taken evidence-based practices and they have inculcated by removing the child and adolescent section group. Further, for example, autism. If you take autism, it's not just one disorder, it is a spectrum. Hence, they've started with autism spectrum disorder, which not only manifests in the childhood or in the early part of the life, it continues to be in the lifespan. Hence, they have taken the lifespan approach and they've removed from the child and adolescent group and they have given a complete category of psychiatric disorders. Moving further, they have removed two important categories from International Classification of Disease 11 from psychiatry chapters. That means from chapter 6, it has been moved out. They are two important. One is sleep-wake disorders and sexual health disorders. So now they have given a separate dedicated chapters. That means they are no more considered as a mental health and behavioral problem diagnosis. Further, if you look at this, sexual health also includes transgender. That means transgender has been removed from the diagnosis of mental illness and they are kept in the sexual health disorders. What does it mean? Simply, the WHO drafter felt that removing transgender from the mental health category and keeping it separate will decrease the stigma. But however, the diagnosis of transgender has been retained for the purpose of two important reasons. One is the presence of diagnosis will give importance for policymakers to invest in policy or invest money to provide care for transgender. One. Second one, if there is a requirement of insurance for the persons with transgender, if you don't classify it as a disorder, invariably none of the health insurance will give any kind of support for SRS or any kind of other illness. Hence, the main reason for keeping this transgender as a diagnosis in ICD-11 is for the purpose of policy and health insurance. Let's look into the difference of ICD-11 and 10. If you look at on one side, there is ICD-10 classificator system and ICD-11 on the other hand. If you look at the ICD-10, it was considered as, the chapter 5 was considered as mental and behavioral disorders chapter. Whereas in ICD-11, it is chapter 6, it is called as mental, behavioral or neurodevelopmental disorder chapter 6. So chapter 1 under the chapter 5 of the ICD-10, it talks about organic disorders. Whereas in ICD-11, you can see it is a neurocognitive disorder is the first one. Along with this neurocognitive disorder, they've added disorders with neurocognitive impairment as a major feature. So that comes separately in the end. Moving to the second chapter in ICD-10, that is basically drug abuse and substance use. Whereas if you look at the ICD-11, it talks about disorders of substance use and addictive disorder way down, that is after the 6C40, that means it is kept below, that is almost down the ladder it has been placed. If you look at the third chapter in ICD-10 is schizophrenia, schizotypal and delusional disorder. Whereas in ICD-11, it has been called as schizophrenia or other primary psychotic disorder, and catatonia has been given a separate subchapter under ICD-11. Whereas in ICD-10, it was a part of schizophrenia. Moving further, if you look at the mood disorder, it was considered as in ICD-10 as mood and affective disorder, whereas in ICD-11 it is only mood disorder or it is considered as bipolar disorder. Moving to the neurotic stress-related somatoform disorder was there in ICD-10, whereas in ICD-11 this somatoform diagnosis has been completely removed and there have been new various classification has been placed. One is anxiety-related disorders, obsessive-compulsive and related disorders, dissociative specifically associated with stress, dissociative disorders, and its somatoform disorder has been newly named as disorders of bodily distress and bodily experience. That is the category which has been given in ICD-11. Moving to the next chapter, fifth chapter under ICD-10 is behavioral syndrome associated with physiological disturbance and physical factors. It is talking about eating disorders and elimination disorder. Whereas in ICD-11, they has been called as feeding and eating disorder separately, mental or behavioral disorder associated with pregnancy, childbirth and puerperium, and then finally psychological or behavioral factors affecting or classified elsewhere has been given. Moving to ICD-10, they have talked about disorders of adult personality and behavior, and they have classified personality disorders into various categories, and whereas in ICD-11, those category completely has been removed. That means personality disorder, by the virtue of various research results, they have said that most of the personality disorders are mixed personality disorders. That means having a purer form of either paranoid personality disorder, schizoid personality disorder, dependent PD, or anxious avoidant personality disorder. Having a purer form is very rare, and those rare diagnoses and rare management will not add anything to the research. Hence, they have kept a simple one as personality disorder. And these personality disorders have various traits which have been mentioned. That is, the person's functionality with regard to self, with regard to the people whom he is around interacting, that is, the future which is very essential is interpersonal relationship, that is the second one. Third one is psychosocial functioning. Fourth one they have considered as behavioral disorders, that is basically to consider the issue of borderline personality disorder, that is impulsivity has been captured. And the final one is cognitive, affective and behavioral component. So these are the 5 domains which has been given in the personality disorder in ICD-11. But in ICD-10, it was a classificatory system. In mental, retardation has been given here, but intellectual developmental disorder comes in the first chapter under ICD-11. Moving further, if you look at the ICD-10, it talks about emotional and behavioral disorders of childhood, especially in ICD-11. They have been completely removed from the classificator system. That is, it has elimination disorder and disruptive disorder, which do not classify only for the child and adolescent. And finally, ICD-10 talks about unspecified mental disorders, whereas in ICD-11 also has a similar formatting. Now let's discuss about new diagnostic subgroup in ICD-11. In ICD-11, the new diagnostic subgroups which have been kept are catatonia. That means catatonia has been given a separate chapter under ICD-11. Further, bipolar 2 disorder has been given a separate importance in ICD-11. Body dysmorphic disorder has been considered under the OCD and OCD-related disorder, olfactory reference disorder, hoarding disorder. Although hoarding disorder cuts across psychosis, bipolar disorder, obsessive compulsive disorder, organic brain injury, in dementia, and also in certain personality disorder. But ordering also has been given a separate chapter. Excoriation disorder is also under the ICD-11. A separate chapter has been dedicated. Further, PTSD was there in ICD-10. In ICD-11, a complex PTSD has been introduced. Here, the complex PTSD is basically if there is a repeated trauma which is prolonged and where the person has a multiple stressors which has been for a longer duration, and the persons will have complex PTSD. These are the people who are very difficult to treat. To capture complex PTSD, what are the course and outcome? Hence, there has been a separate chapter has been dedicated under the ICD-11. Further, there is a prolonged grief disorder has been added in ICD-11. Binge eating disorder is there. As you look at in ICD-10, we had only anorexia nervosa and bulimia nervosa. And one more has been added is binge eating disorder in ICD-11. Further, avoidant and restrictive food intake disorder has been given importance in ICD-11. And finally, the body integrity dysphoria has been added with regard to ICD-11. Gaming disorder, that is behavioral addiction, gaming disorder and gambling disorder has been given, considering both physical and also virtual addiction has been considered. Further, compulsive sexual behavior disorder, where a person has watching pornography, it may be there, failure to control intense repetitive sexual impulses, those has been added. Further, in ICD-11, intermittent explosive disorder and also premenstrual disorder has been given importance in ICD-11. So these are the various new chapters have been added in ICD-11. In ICD-11, there are new 10 more chapters have been added. That means let's move further. Discussion about categorical approach augmented with dimensional. As you know, international classification of disease has been criticized being highly categorical in nature. Of course, categorical approach started from DSM-3. Basically, we wanted to have inter-rater reliability between two physicians, that the diagnosis is same across all physicians from the primary care to the tertiary center. Hence, categorical approach was taken especially in ICD, whereas DSM over a period of from DSM-4, 4R and 5, they took a dimensional approach. In ICD-11, now, although the categorical approach of classification of disease in ICD-11 is retained, but they have augmented with the dimensional. Let's look into that. Basically, ICD-11 continues to hold the categorical approach, but however, they have added the dimensionality spectrum, considering the severity of illness will be coded, course of the illness will be coded, is there any specific symptoms which need to be diagnosed will be added, and sometime even the treatment response will be coded. That means in ICD-11, with the categorical approach, the dimensional approach has also been considered. The categorical approach of diagnosis is very essential from the perspective of primary care doctor and also the doctors who are involved in coding and also making diagnosis and planning for treatment management. Whereas dimensional approach becomes very useful in research, especially when we are unable to find this categorical approach any scientific evidence for diagnosis, but similarly in the research. Hence, in research, we need to look into the symptom dimension, severity dimension, course and outcome dimension, genetics, neurocognitive aspects, neuroimaging aspects, and so forth, so that bringing all these aspects may give you a breakthrough with regard to neurobiology. Hence, we need to have a dimensional approach and also categorical approach. ICD-11 has made an attempt to keep both categorical and dimensional approach in certain disorder. Now the question comes, why should we have two different categories of system like ICD-11 and DSM? Should we have both? Of course, there is a merit and also demerit having in both. If you look at the DSM 3, 4 and 5, over a period of time, the dimensional aspect has been borrowed into ICD 10 and 11. That means over a period of time, we are borrowing certain things from DSM. Similarly, the DSM is also borrowing certain things from ICD 11 and ICD 10 also it has borrowed. That means having two classificator system allows not only for the purpose of the policymakers, but also for the purpose of research. Hence, it looks artificial in having two categories of ICD-10, ICD, and DSM. But from the larger perspective, from the prospective perspective, for doing research purpose, having two types of classificator system makes sense for the system to grow over a period of time. Hence, having both looks good over a period of time. But however, if you look at cross-sectionally, why should we have two? The students will have difficulty. Coding will be difficulty. Policymakers will have difficulty. It depends upon the region which they want to adopt. But having two classificator system helps us to do research from two different angles, and approaching a problem in two different perspective also gives some amount of clarity, and sometimes we can borrow from other group also. Let's look into the biological versus symptom-based framework for classificator system. As you know, the symptom-based classification is for psychiatry. Unfortunately, from the dimensional approach, we are unable to reach nowhere. And even from the neurobiological aspect, we are unable to reach nowhere. From the functioning system, we look into the classificator system, whether there is a negative valence, positive valence of framework, cognitive related, social process related, arousal, or else sensimotor be related classificatory. Will it work? Unfortunately, we have reached nowhere. Further, if you look at the biological approach of unit of analysis, 8 unit of analysis has been done for most of the disorders, such as genetics at the molecular level, proteomics level, circuits, neurophysiological basis, behavioral based, self-report, and paradigm report. So unfortunately, this also has not yielded much. So symptom-based for diagnosis at the primary care level, communicating the diagnosis, communicating the treatment, and insurance purpose, the symptom-based continues to hold good at this point of time. The day may come in near future where it is the classificator system may be based upon the neurobiology, like tuberculosis, formed by tuberculous bacilli. Similarly, we may come to know what are the reasons for schizophrenia, and based upon the etiological factor, we may classify the diagnosis. Now let's move into the ICD-11 chapter 6. The first one is neurodevelopmental disorders. If you look at the neurodevelopmental disorder, it is considered as 6A0. The neurodevelopmental disorders has a lifespan approach starting from intellectual developmental disorder, basically mental retardation or intellectual disability. That is the way it has been considered. Further, once you have discussed about the developmental disorders with regard to mental retardation or a global intellectual decline or disability or difficulty to form, immediately it moves to developmental of speech and language disorder. The next one is autism spectrum disorder, developmental learning disorder, developmental motor coordination disorder, and attention deficit hyperactivity disorder comes in the first chapter, and also stereotype movement disorder. So this is the way the ICD-11 has taken the approach with regard to the first chapter under ICD-11. However, the chapter 1 of neurodevelopmental disorder is a welcome step. However, it has its own criticism. For example, schizophrenia is also considered as a neurodevelopmental disorder. Early childhood mood disorder is also considered as a neurodevelopmental disorder by some of the researchers. Substance use disorder is also a neurodevelopmental disorder. But we do not have much of evidence. Can we just ignore it and say it is not a neurodevelopmental disorder? Although nothing comes out of zero. There should be a neurobiological basis. But at this point of time, the classificator system decided these schizophrenia, bipolar disorder, substance use disorder require some respect to be kept in a separate chapters. Whereas other neurodevelopmental disorders have been clustered and kept in one place. But however, there is also putting in one place is lumping and splitting, both have been taken under ICD-11. As I mentioned, both categorical approach and dimensional approach has been taken in ICD-11. Further, moving to the second important category is schizophrenia or primary psychotic disorders. Compared to ICD-10, it was considered as schizophrenia, acute psychosis, and or delusional disorder. Looking into the schizophrenia, here it has been classified under as schizophrenia, schizoaffective disorder, schizotypal disorder, acute and transient psychotic disorder, delusional disorder, and symptomatic manifestation of primary psychiatric disorder. If you look at this classificator system, subtypes of schizophrenia has been removed. That means paranoid schizophrenia, catatonic schizophrenia, undifferentiated schizophrenia, post-depression, post-schizophrenic depression, hebephrenic schizophrenia, disorganized schizophrenia. Those categories have been completely removed in ICD-11 to harmonize with DSM-5. But however, in ICD-11, the symptom specifier has been given importance. Positive symptoms, negative symptoms, depressive symptoms, manic symptoms, psychomotor, that is basically for catatonia, and cognitive symptoms. Further, the dimensional aspect has also been considered with regard to core specifier. That is, longitudinal perspective. Is it a first episode, episodic illness, or a chronic illness? Further, cross-sectionally, whether the person is having symptoms or partial remission or in full remission. That means if you are going to get a complete snapshot of a picture when a person is diagnosed, telling that patient has schizophrenia with positive symptoms in a episodic illness, currently in remission. That means you will be able to understand what type of schizophrenia persons with schizophrenia and what circumstances he is there and what are the diagnoses, whether he is remitted, not remitted, episodic. That means you'll be able to get a complete picture by getting the diagnosis. Further, acute psychosis remains same. Here, subtypes of acute psychosis have been removed, and the subtype of acute psychosis which have been retained as a complete acute psychosis is which is having acute onset, brief duration, and polymorphic in nature. That means rapidly changing picture. It may have hallucinatory behavior, mood symptoms, again depression, maybe manic symptoms, hallucinatory changes, delusions. Those have been retained here. Whereas acute psychosis, purely delusional type, purely hallucinatory type have been changed. That means we are going to see acute psychosis with the onset within 2 weeks and not lasting more than 1 month. That will be considered as acute psychosis. And now, the other chapter has been given complete importance as catatonia. Again, you need to understand, in ICD-10, catatonia was completely a mess. The catatonia was considered under schizophrenia. That means if you have to make a diagnosis under depression, it was not given importance. And catatonia in the reason for organicity was also not being considered in ICD-10. Whereas in ICD-11, the due credit has been given here. A separate chapter has been given. Further, the division has been very clear. Catatonia with another mental disorder. Mental disorder may be schizophrenia, maybe because of depression, because of mania, can be diagnosed here. Further, the classification also goes into say catatonia induced by psychoactive substance and or medications. That means here there is a separate category has been added. Further, catatonia with regard to the causes of medical condition also has been added. Further, moving to bipolar disorder. Here, the affective word has been removed in ICD-11. Here only bipolar disorder 1, bipolar 2 disorder has been given a complete freedom and separate category has been added. Further, cyclothymic disorder has been added here. Moving to depression. The depression has been considered as single episode of depression, recurrent episodes of depression, dysthymic disorder, and commonest diagnosis which we often make in primary care is mixed depressive and anxiety disorder. That has been given importance. Further, rapid cycling continues to retain but under the depression. Moving further, here in depression, the dimensional aspect has been added. Symptom specifier for depression is been considered, whether it is melancholic, whether predominantly anxiety symptoms, whether with panic attacks, whether with psychotic symptoms, or whether there is a seasonal pattern. Further, severity specifier, mild, moderate, severe, longitudinal, whether it is a first episode or episodic illness or chronic illness. Further, cross-sectional, whether it is symptomatic, partial remission or in full remission. That means again a snapshot of a patient will give you a complete picture. Further, earlier in ICD-10, anxiety and stress related was the chapter given. Here, anxiety and fear related disorders have been added. That means there has been a change in the nomenclature. Here, in ICD-11, generalized anxiety disorder, panic disorder, agoraphobia, specific phobia, social anxiety disorder, separation anxiety disorder, selective mutism comes here. That means it is moved out of the dissociation. Selective mutism comes here, and invariably the research has been considered here to say that selective mutism usually seen in children with regard to acute anxiety. Hence, it has been coded here. Further, obsessive compulsive or related disorders have been a separate chapter similar to DSM-5. Let's look into the OC spectrum. Here, the OC spectrum which have been added under the obsessive compulsive or related disorder is OCD, body dysmorphic disorder, olfactory reference disorder, hypochondriasis, and hoarding disorder. And these all 5 disorders also has been considered as an insight has been considered. Each disorder will be termed as fair to good insight or poor to absent insight has been given here. Here in ICD-11, they discourage to make a delusional disorder with regard to either BDD or OCD or olfactory reference syndrome. They say that they have a good response to SSRI. Hence, this insight is a dimension has been added. Further, under the obsessive compulsive and related disorder, body focused repetitive behavior has been considered. That is trichotillomania and excoriation, that is skin picking. Moving to the disorders specifically associated with stress. Those are PTSD, complex PTSD has been given importance here, prolonged grief disorder, adjustment disorder, reactive attachment disorder, disinhibited social engagement disorder has been added here. Moving to the dissociative disorder. Again, dissociative disorders have been given a subtype and separate chapter has been dedicated. Starts with dissociative neurological disorder with regard to visual, with regard to auditory, dizziness, sensory, epileptic, paralysis, gait, movement, disturbance have been given importance under dissociative neurological disorder. Further, dissociative amnesia, possession and trance disorder, dissociative identity disorder, depersonalization and derealization is part of dissociation now. Further, feeding or eating disorder has been also considered. Here, feeding or eating disorder is basically anorexia nervosa, bulimia nervosa, and binge eating disorder have been added here. Moving to elimination and bodily distress disorder. Let me remind you, till now we have not discussed about somatoform disorder. Somatoform disorder has got a new name under ICD-11, that is bodily distress disorder. Let's look into this. Elimination disorder considers enuresis and encopresis. Nocturnal, diurnal or both are the dimensional aspect. Moving to the disorders of bodily distress syndrome is basically somatoform disorder. Further, they are considered as under bodily distress disorder. The main reason for considering this is somatoform disorder means a person is acting, we do not have real symptoms, and unfortunately we do not know the neurobiology at this point of time. Hence, there is a stigma needs to be decreased. This need to be investigated. Hence, to encourage the researcher, to encourage the clinician and policy reformers to consider them as a separate entity as a bodily distress disorder. Hence, it has been given a dimensional aspect of severity. If a person spends or preoccupation with bodily symptoms is less than 1 hour per day, it will be considered as mild. If it is more than 1 hour, it is considered as moderate. If he is spending most of the time thinking about these symptoms and asking for various consultation, it will be considered as severe. It is depending upon the impairment of functioning. And coming to the substance use disorder. Substance use disorder and ICD-11 has been given more flexibility in adding to the newer substance abuse. Starts with alcohol, cannabis, synthetic cannabinoids have been added, opioid, sedatives, hypnotics, cocaine, stimulants, synthetic cathinoids have been added here, caffeine, hallucinogens, and nicotine. Further, disorders to use of nicotine, volatile inhalant, MDA substances, dissociative drugs have been considered as ketamine and phencyclidine given a separate category, and also disorders due to other drugs have been added, and also disorders due to use of multiple drugs been given separate entity under the substance use disorder. It looks almost similar to ICD-10, but however, delirium can be diagnosed under any of these substances. That means even cannabis sudden withdrawal can cause delirium has been considered under the ICD-11. Further, It also been given disorders due to addictive behaviors. Addictive behaviors like gambling and gaming has been given. Further, impulse control disorders like pyromania, kleptomania, intermittent explosive disorder, compulsive sexual disorders have been under this category. Further, disruptive behavior or dissocial disorder like ODD also comes into this picture. Further, personality disorder, which I mentioned earlier, here under ICD-11, personality disorder removes all the classification and stands alone as a personality disorder. Further, paraphilic disorders, factitious disorder, neurocognitive disorders and dementia has been added in the last chapter along with the personality disorder. But however, you need to remember personality disorder is based on functioning of the identity of self, relationship with others has been considered along with the psychosocial functioning, further cognitive, emotional and behavioral aspect will be considered in the diagnosis of personality disorder. The earlier classificatory of personality disorder like ABC classificatory system has been removed. Individual personality disorder like 10 personality disorder which is there in ICD-10 has been removed. But however, the traits have been retained. For example, negative affective trait, detachment, dissociality, disinhibition, anancastic and borderline pattern has been given so that usually when we diagnose personality disorder, invariably it will be multiple personality disorder. The pure type of having anancastic personality disorder or else pure type of paranoid personality disorder is very rarely to seen. Hence, they have been given a complete overhaul of the personality disorder has occurred both in DSM-5 and ICD-11. Further, they have added to the dimensionality the severe. Mild, moderate, severe classificator system has been added under the personality disorder. Finally, the separate category has been given mental or behavioral disorder associated with pregnancy, childbirth, and with the puerperium has been added, where with or without psychotic symptoms have to be dimensionality as aspect has been given. But however, remember this, sleep-wake cycle disorders, sexual disorders, gender incongruence, the transgender has been removed from the psychiatry. They have been given a separate category under ICD-11. That means they no longer will be considered as mental disorders. To conclude, my dear friends, ICD-11 has been magnanimous. Another 10 different subcategories have been added. That means under ICD-11, we will have 21 different subchapters. Whereas in ICD-10, it was hardly 11. Although there has been a significant improvement in biological understanding of psychiatric illness, but still, we are far away for classificator system based upon neurobiology. That means we have a evidence gap for classificator system in neurobiological perspective. But still, we continue to have the classificator system both in DSM-5 and ICD-11 based upon symptom cluster. That is, we have a categorical approach in ICD-11, but also they have borrowed the concept of dimensionality from DSM-5. This gives a new perspective under ICD-11. Hence, my dear friend, ICD-11 is a promising and needs to be adapted at the earliest. Though as the research new findings are accumulating, ICD-11 and DSM-5 is going to evolve. And we need to be along with the classificator system so that our diagnosis and our treatment approach can contribute for the future to come. Thank you very much for giving your valuable time. Stay safe.